Interpreting chest X-rays. What are X-rays? X-rays are a form of ionizing radiation. They are part of the electromagnetic spectrum and have sufficient energy to cause ionization. They contain more energy than ultraviolet waves, but less energy than gamma rays. Ionization is a process whereby radiation removes an outer shell electron from an atom. The ionizing radiation is able to cause changes on a molecular level in biologically important molecules such as DNA. In the photo provided, you can see the electromagnetic spectrum from highest to lowest frequency. As can be appreciated in the photo, cosmic, gamma, and X-rays form part of ionizing radiation, which can be potentially harmful to humans. How are X-rays produced? X-rays are produced by focusing a high-energy beam of electrons onto a tungsten target. If the electron has enough energy, it can knock out another electron from the inner shell of a tungsten atom. As a result, electrons from higher energy levels then fill up this vacancy and X-rays are emitted. This process of producing X-rays is extremely inefficient. So most of the energy in the beam of electrons is wasted as heat. This is why X-ray tubes need to have advanced cooling mechanisms. The X-rays produced then pass through the patients onto a detector mechanism which produces an image. The resulting image in an X-ray film is a two-dimensional representation of a three-dimensional structure. While passing through a patient, the X-ray beam is absorbed in proportion to the cube of the atomic number of the various tissues through which it passes. By convention, the greater the amount of radiation hitting a detector, the darker the image will be. Materials of low density appear darker, while materials of high density appear lighter on the image, and structures can be appreciated on the film according to how they are contrasted with surrounding tissues. Looking at the figure, you can see that the least dense structures, such as air for example, in the lungs, appear black, while those that are very dense, such as prosthetics or bullets, will appear bright white. And structures with different densities will appear in different shades of gray. The standard view is a PA or posterior anterior erect view. All chest X-rays are taken at this view unless otherwise specified. The patient stands with the anterior chest wall up against an X-ray film. The X-ray tube is placed optimally 6 feet behind the patient, so the X-rays pass in the posterior anterior direction. The patient takes a deep breath and holds it during the X-ray to ensure adequate inspiration. X-rays are done in PA view to ensure accurate assessment of the cardiac size due to minimal magnification and so that the scapulae may be rotated out of the way. They are done erect because gas passes upwards and fluid passes downwards. It also provides a physiological representation of blood vessels and lungs. There are of course other views which X-rays can be done, such as anterior-posterior or supine chest X-rays, lateral chest X-rays, expiratory PA erect chest X-rays, and apicolordotic view. An anterior-posterior or supine chest X-ray is performed when the patient is too ill to stand. The plate is then placed on the patient's back and the X-ray tube is placed in front. The major disadvantage of this is that the mediastinum and the cardiac size will appear wider due to venous distension and magnification. Lateral chest X-rays are done to give further views of the lungs and heart when more details on the anatomic locations of lesions is needed. Expiratory PA erect chest X-rays are done rarely and are used to detect a suspected pneumothorax or a suspected bronchial obstruction with air trapping. And finally, an apical ordotic view focuses on the apices of the lungs to better visualize densities in that area, often seen in pulmonary tuberculosis. This shows the normal anatomy on a PA chest X-ray. Remember, as you look at the chest X-ray, the left side of the radiograph is the patient's right side, while the right side on the radiograph is the patient's left side. So number 1 is the patient's right side, while number 2 is the patient's left side. The area shaded orange is the mediastinum. The mediastinum is the central compartment of the thoracic cavity. It contains the heart, great vessels, esophagus, trachea, phrenic nerve, vagus nerve, sympathetic chain, thoracic duct, thymus, and central lymph nodes. This again shows a normal chest X-ray with normal pulmonary vascular patterns. Normal lung vascular pattern has the following features. Number 1, arteries and veins branch vertically to upper and lower lobes. Number 2, the upper lobe vessels have a smaller diameter than the lower lobe vessels in an erect chest X-ray. The white dotted line is the level at which the pulmonary vessels enter and leave the lungs. The red shaded portion are the vessels, and as you can see, the vessels branching upward, those that are located above the dotted line, are generally smaller than the vessels branching downwards, those that are located below the dotted line. This is due to the effects of gravity. Clinically, changes in these are appreciated in pulmonary venous hypertension, where the vessels branching upwards become larger than the vessels branching downwards. Normal lung markings are actually blood vessels in the lungs. They are visible on a chest radiograph as the X-rays are absorbed by the iron in the blood. If each lung is divided into 3 from the inside to the outside, you can appreciate how normal lung markings change. In the photo, the first third is the area closest to the mediastinum, and in this area, you will be able to appreciate clearly defined vessels and bronchial branches. The middle third of the lung, as you move into the middle third of the lung, these become smaller and more difficult to see. And finally, when you move into the outer third, the portion that is closest to the pleura of the lungs, you will see fine pattern of branching lines with no easily defined vessels or air spaces. This slide shows the different anatomic landmarks you will see in a normal chest X-ray. Number 1 in light blue is the trachea. Number 2, represented by the black dotted line, is the carina, which also corresponds to spinal level T5. Number 3, the green line, is the aortic arch or aortic knuckle. Number 4, as the green dotted line, is the descending aorta. Number 5, which is the yellow line, represents the left ventricle. Number 6, which is the pink line, is the left hemidiaphragm. Number 7, which is the purple line, is the right hemidiaphragm. Number 8, which is the red line, represents the right atrium. And number 9, the purple line, is the superior vena cava. The left ventricle forms the left heart border, and the right atrium forms the right heart border. The left atrium and the right ventricle are not visible on a normal chest radiograph. This is because the right ventricle lies anteriorly and the left atrium lies posteriorly, and they therefore have no definable border on chest X-ray. Imagine how the lungs would look like inside the chest. Number 1 is the trachea. Number 2 is the carina. 3 is the left main stem bronchus, which separates into 5 and 6, which are the left upper lobe bronchus and the left lower lobe bronchus, respectively. Number 4 is the right main stem bronchus, which separates into 7 and 8, which are the right upper lobe bronchus and the intermediate bronchus, which separates into 9 and 10, the middle lobe bronchus and the right lower lobe bronchus. These bronchi correspond to the different lobes of the lungs as shown on this slide. Number 1 is the right upper lobe, 2 is the middle lobe, 3 is the right lower lobe, 4 is the left upper lobe, and 5 is the left lower lobe. Number 6, between 1 and 2, is the horizontal fissure. Number 7, between 2 and 3, is the right oblique fissure. Number 8, between 4 and 5, is the left oblique fissure. Remember the anatomy of the lungs? Only the right lung has a middle lobe. After learning the normal anatomy in a chest radiograph, we now move on to presenting a chest radiograph. What is important to remember when you are interpreting and presenting a chest radiograph is that you should present in a systematic way to ensure you cover all areas and do not miss anything important. This is how you should present. Number 1, give the type of radiograph and the projection. Example, this is a PA chest radiograph. Number 2, give the patient's name. Example, this is a PA chest radiograph of Juan de la Cruz. Number 3, give the date the X-ray was taken. Example, this is a PA chest radiograph of Juan de la Cruz taken on the first day of January 2020. Number 4, briefly assess the film quality to ensure it is adequate. Number 5, run through the ABCDE of chest X-rays. And number 6, give a short summary in the end. Number 4, 5, and 6 will be discussed in the next slides. Number 4 in the steps in presenting a chest radiograph is assessing film quality. This is done by assessing rotation and adequate inspiration. Adequate inspiration is important because if the inspiration is too shallow, then the heart may appear falsely enlarged, giving the false appearance of cardiomegaly. Also, if the lungs are not adequately inflated, the vessels at the lung bases can look more prominent and give the false appearance of consolidation or collapse. How do you assess rotation? Look at the spinous processes of the upper thoracic vertebrae. If the patient is not rotated, they should lie midway between the medial ends of the clavicles. If the patient is rotated, the spinous processes of the upper thoracic vertebrae will not lie midway between the medial ends of the clavicles, but will be deviated to either the left or the right. It is important to assess rotation as a rotated film can make the heart and mediastinum look larger or smaller than they actually are. In this slide, the photo on the left, you see both clavicles marked in yellow. The medial ends of the clavicles are marked with a black dotted line. The position of the spinous processes is marked with a white dotted line. You see the white dotted line positioned midway between the black dotted lines. Therefore, this radiograph is not rotated. On the photo on the right, the landmarks are marked in the same way. You see the black dotted lines deviated to the right of the white dotted lines. This radiograph is rotated to the right. How do you assess adequate inspiration? If the hemidiaphragms lie at the level of the 6th anterior rib or below, then the inspiration is adequate. Alternatively, if there are 8 or 9 posterior ribs visible in the lung fields, this is also adequate inspiration. Look at the photo on the left. The photo represents adequate inspiration. The anterior parts of ribs 1 to 6 are marked in yellow. The left and right hemidiaphragms are marked in orange. Note how the diaphragm has a normal dome shape and not flattened. If the lungs are underinflated, then there will be 5 or fewer anterior ribs or 7 or fewer posterior ribs visible overlying the lung fields. Now look at the photo on the right. This is an example of inadequate inspiration. Notice how the lung volume is markedly decreased. There is false appearance of cardiomegaly. The ribs marked in yellow only show anterior ribs 1 to 4. Now we will discuss the ABCDE of chest X-ray. A stands for airway. Look at the trachea, right and left mainstem bronchi, and intermediate bronchus. B stands for breathing. Look to see if the lungs are uniformly expanded and compare the lung fields. Look around the edges of each lung. Look at the 4 silhouettes, which we will discuss later. C stands for circulation. Look at the cardiac size. Look at the great vessels, such as the pulmonary vessels and the aorta. Look at the mediastinum and hyla. D stands for disability. Look for a fracture, especially of the ribs or shoulder girdle. E stands for everything else. Look for air under the diaphragm. Look at the edges for subcutaneous emphysema. Look for the breast shadows, especially in females. Look for foreign bodies and other abnormal or unusual findings. For the airway, you look for tracheal deviation and you take a look at the carinal angle. For tracheal deviation, the trachea is considered to be deviated if a portion anywhere along its length is completely to the left or right of the midline. Remember that the midline is the center of the vertebral column as indicated by the spinous processes. When assessing for tracheal deviation, be sure to check that the film is not rotated, as a rotated film can give the impression of tracheal deviation when the trachea is actually central. Look at the photo. These are 2 identical radiographs. On the right, the trachea is shown in blue, and this shows right tracheal deviation. If the trachea is deviated, you should look for a possible cause within the radiograph. If the trachea is deviated towards the deceased side, meaning the trachea is pulled, possible causes are lung collapse, pneumonectomy or lobectomy, unilateral fibrosis, agenesis of the lung. If the trachea is deviated away from the deceased side, meaning the trachea is pushed, possible causes are tension pneumothorax, a large pleural effusion, mediastinal masses, or paratracheal masses. The carinal angle is the angle between the left mainstem bronchus and the right mainstem bronchus. Normally, the angle is between 40 and 100 degrees. An increase in the carinal angle is an indirect sign of pathology in the heart, mediastinum, or lungs. Therefore, if the carinal angle is greater than 100 degrees, then look for a pathology that may be causing this. Look again at the photo in the slide. These are 2 identical radiographs. The areas shaded in blue are the trachea, the right and left mainstem bronchi. This shows widening of the carinal angle. Possible causes for a widened carinal angle are a subcarinal mass, left atrial enlargement, cardiomegaly or pericardial effusion, or right or left upper lobe collapse, pulling the mainstem bronchus upwards. B stands for breathing. The basic rule is black is equal to air and white is equal to no air. For breathing, there are 5 main things to look at. Number 1, are the lungs uniformly expanded? Number 2, compare the lung fields and look for white areas. Compare the left apex with the right apex. the left upper zone with the right upper zone, the left mid zone with the right mid zone, and the left lower zone with the right lower zone. Look around the edges of each lung, look at the costophrenic angles, and look at the 4 silhouettes. The 4 silhouettes are marked on the right radiograph. Number 1 in red is the right heart border, number 2 in yellow is the left heart border, number 3 in purple is the right hemidiaphragm, and number 4 in pink is the left hemidiaphragm. Loss of the right heart border indicates a loss of air in the middle lobe due to collapse or consolidation. Loss of the left heart border indicates a loss of air in the lingula. Loss of the clear diaphragmatic silhouettes indicates there is a loss of air in the lower lobe in collapse or consolidation, or that there is something between the diaphragm and the lower lobe of the lung, such as fluid. C is for circulation. Look at the cardiac size. The width of the heart should be no more than half the total width of the thorax. This is referred to as the cardiothoracic ratio. Normal ratio is around 0.5, which means it should not be more than that value. Look at the great vessels, which are the pulmonary vessels and the aorta. In a normal radiograph, this is reported as the heart size is normal, there is no mediastinal shift, the mediastinal contour and hyla appear normal. D stands for disability. Look for any fracture or bony disability of the ribs. If you look at the photo on the slide, the radiograph was rotated 90 degrees. This is done because when you look at the radiograph normally, your eyes are trained to look at the anatomy of the lungs and the heart. However, rotating the image tricks your brain and your eyes tend to focus on the more dense parts such as the ribs and other bones, making it easier to spot a fracture or bony abnormality. You can step closer to the radiograph and follow the edges of each individual bone to look for fractures. Look for areas of blackness within each bone and compare the density of the bones on both sides. They should be the same. Repeat, looking for any fracture or bony abnormality on the vertebrae, clavicles, or shoulder girdle. E stands for everything else. Look at the hemidiaphragms, specifically for air under the diaphragm. Normally, both hemidiaphragms peak in the center, and the right hemidiaphragm is higher than the left due to the position of the heart. Other intra-abdominal pathologies you may see are areas of calcification under the right hemidiaphragm, which may represent gallstones, and dilated loops of bowels under the hemidiaphragms. Look at the edges of the body and all over the film for subcutaneous emphysemas. In a female patient, look for the breast shadows. If one breast is smaller or missing, it could indicate a previous mastectomy. Check the axillae and lower neck for masses. Look for foreign bodies or other unnatural presences. As an example, a normal chest x-ray can be presented this way. This is a PH chest radiograph of Juan de la Cruz taken on the first day of January 2020. The trachea is central, the lungs are uniformly expanded, and the lung fields are clear. The heart size is normal, there is no mediastinal shift, the mediastinal contours and the hyla appear normal. There is no fracture or bony abnormality. There is no evidence of air under the diaphragm, surgical emphysema, or any foreign body. In summary, this is a normal chest x-ray. This is the end of part 1 of chest x-ray interpretation, which deals more on the normal anatomy of a chest radiograph and recognition of landmarks. Part 2 will cover abnormalities that can be seen on a chest X-ray. Thank you.